So good morning, everyone. Thank you so much for being here with us this morning, this roundtable. And please let me also thank the Regedenf company for the great opportunity to share with you our clinical experience concerning the application of hyaluronic acid in the palatal donor site following free gingival graft harvesting. And I think that if we are all here in Sitges during this Congress in this magnificent venue, it is because Monday morning we would love to have an happy patient and a satisfied patient following our surgical procedure, rather than a patients that refer pain, swelling, and discomfort. And I think this is the reason why the industry is always looking forward new molecules that can modulate all the inflammatory phase and thus reduce the overall postoperative patient morbidity. And this becomes really important when it comes to the optimization of the peri-implant phenotype, which we know plays a critical role in the long-term stability of our implant-supported restoration. And we know that the goal is to achieve at least 2 millimeters of keratinized mucosa width and 2 millimeters of mucosal thickness in order to have predictable results on the long term. And the literature is pretty clear in stating that connective tissue graft and free gingival graft are the golden standard procedures actually available in order to have a good mucosal thickness and a good mucosal width, respectively. However, let's say unfortunately, most of the procedures that we will perform to our patient, and among all of them, palatal soft tissue harvesting is the one associated with a higher level of postoperative patient morbidity. And the pain is the most documented drawback in this procedure. So how many patients in our clinical practice may or are likely to expect excessive pain or delayed wound healing or mild bleeding? Well, actually, almost 30% of our patients, so 1 out of 3. And unfortunately, again, irrespective of the timing of the complication, being that an early complication or a late complication, pain remains the most common postoperative complication that can negatively impact the quality of life of our patient. But this is not enough. The problem is that the pain also reduces the willingness of the patients to perform additional treatment. So it is likely that if you ask to one of these patients that already experienced pain to undergo future treatment like other palatal soft tissue grafting, he will probably say, no, I don't want, because the last time I felt excessive pain, excessive swelling, and therefore I'm okay like that. So is there an effective way to control this pain perception following free gingival graft removal? And these meta-analyses clearly show us that if we apply methods, including, of course, the hyaluronic acid, in the palatal wound healing, we will be able to drastically reduce the postoperative pain perceived by the patients, compared, of course, to the natural healing after 7 days of healing. So all of these materials should meet specific requirements, including, of course, antibacterial and hemostatic properties, the ability to promote epithelialization, and the capacity to control and reduce pain as the most biologically driven properties. And among all of these materials that have been marketed, actually the hyaluronic acid, either used alone or associated with other materials, is associated with low pain levels of our patients. So it should be really important to use hyaluronic acid in the palatal wound of our patient. Actually, hyaluronic acid is a natural molecule that is ubiquitously present in the body, including, of course, the mouth of the patients, and in particular all the periodontal tissues like the gingiva and the periodontal ligament, as is mostly synthesized by oral fibroblasts. And in order to understand the importance of the hyaluronian in the palatal wound healing, we should look at how normally happens a healing of a palatal wound. And we can see that there are different phases throughout this period of time starting from immediate postoperative period up to several months to achieve a complete epithelialization. And interestingly, if we look at the literature, hyaluronic acid naturally is present in all of these phases. So you can clearly understand how this molecule may play a crucial role during the healing phase following our surgical procedure. And this is made possible by the different configuration that hyaluronic acid may take. Indeed, it has a high molecular weight hyaluronic acid that becomes important in the early stages of healing within minutes because it binds the fibrinogen and is able to attract the blood clot and stabilize the coagulum and create the space for the colonization of subsequent cell population, and is then degraded by hyaluronidase 1 and 2 into a low molecular weight hyaluronic acid, which is important due to its proangiogenetic properties and the capability to induce cell proliferation and cell migration during the later stage of healing. But the natural and the native hyaluronic acid, unfortunately, have a extremely rapid turnover, and this is the reason why the industry made a cross-linking phase in order to have a cross-linked molecule that can remain in the surgical site for a longer period of time. And this is the reason why now Hyadent is composed of a high molecular weight 1.6% cross-linked hyaluronic acid together with a 0.2% natural hyaluronic acid. And in this configuration, it can exert all the biological properties that we have seen so far during these days in the Congress. And in particular, is able to stabilize the blood clot. It has a bacteriostatic effect, can attract the growth factor, and at the same time, is hopefully reducing the sensation of pain, swelling, and discomfort for our patient. And lastly but not leastly, can induce a scarless wound healing. And of course, due to its high hydrophilic characteristics, can be used in the case of the presence of blood. So as Professor Scullion said during the presentation, we have to go a little back to the origin and understand the in vitro characteristics of hyaluronian, and in particular its interaction with fibroblasts from human and gingival fibroblasts. And what they saw is not only that hyaluronian, and in particular Hyadent in this case, is of course fully biocompatible, but can also exert no negative effects on the viability of fibroblasts, but also can increase the proliferative and migratory ability of such type of cells, both at the palatal and the gingival sites, and can promote cell survival, motility, and proliferation. And if we look at all the characteristics that it has, we can understand that it is really involved in all the molecular pathways that are responsible for a good healing of our surgical wound. So if we translate all of these characteristics into the clinical setting, there are many studies that confirm this hypothesis that hyaluronic acid can improve the healing of the soft tissues. That is the case of this study where the patients were submitted to 3 gingival grafting procedures, and some of them have been treated with hyaluronic acid and other ones have been treated with the control group, so no hyaluronic acid at all. And what the authors found was that during the postoperative phase, pain scores were significantly lower in the test group compared to the control group at 3 and 7 days, as well as the burning sensation was significantly lower compared to the control group on day 3, which means that the high molecular weight hyaluronic acid is able to improve substantially the pain perception and reduce the morbidity of the patient in the immediate postoperative period. But this is not enough. Indeed, the authors also evaluated in the long term the epithelialization and the color matching of the 2 different groups. And they noted that epithelialization of the donor site in the test group is completed faster. Already at 21 days, we can see that when we use the hyaluronic acid, we can have a complete epithelialization of our palatal surgical wound. Whereas if we don't use hyaluronic acid, complete epithelialization will occur at 42 days. At the same time, in parallel, color matching is significantly higher and better in the test group compared to the control group from day 7 up to day 42. And these results corroborates another study that has been published recently in the Clinical Oral Investigation 2 years ago, where The authors evaluated the healing through a VAS score self-reported by the patients, and in one group, patients were treated with a collagen sponge veiculated with hyaluronic acid, while in the other group, the patients were left to heal spontaneously. And what the authors found, even in this case, was that up to 7 days post-operatively, patients that were treated with hyaluronic acid exhibited significantly lower level of pain scores compared to the control group. So based on this finding, we have developed and we are now conducting at the University of Milan under the supervision of our mentor, Professor Majorana, a randomized controlled clinical trial aimed at evaluating this aspect in a group of patients treated with hyaluronic acid. So I invite Dr. Manfredini to share with you our results.
Thank you. This study was approved by our ethical committee in the University of Milan and is designed as a randomized controlled clinical trial analyzing the clinical healing, the patient's morbidity, and the restitutio ad integrum of patients treated for the palatal harvesting for soft tissue augmentation on implants, basically. Clinical healing is evaluated by the Landry Healing Index, where a score from 1 to 5 is given to patients analyzing the tissue color, the bleeding on palpation, the quantity of granulation tissue, if it's present or not, incision margin, if it's epithelialized or not, if it's exposed connective tissue or not, and suppuration, giving a score from 1, very poor, to 5, excellent. Post-operative patient's morbidity is then analyzed with a self-recorded test by the patient where the patient can check a VAS score analyzing the pain at 7, 14, at 3, 7, and 14 days, the discomfort, the chewing impairment, the stress, the bleeding, and the painkillers intake. Patient can get 3 paracetamol 1 gram maximum, and they have to record how many, okay, in the days after surgery. Also, a restitutio ad integrum is analyzed with digital scan, and by superimposing and comparing between different points, the STL superimposed at 7, 14, and 2 months after surgery, we can tell how fast the tissue heal with in the test group and in the control group. This is the harvesting technique and the hyaluronic acid application. The hyaluronic acid is vehicled by a collagen sponge fixed to the palate then with horizontal cross matrices, as you can see. The suture, the hyaluronic acid application inside the sponge, and then the sponge is fixed with horizontal cross matrix to the palatal donor site. Okay. Here's some cases treated with soft tissue augmentation and before with GBR procedure. As you can see in this lateral picture, we have a vertical and horizontal defect at 2 millimeters vertical defect, so we can treat it with a so-called sausage technique with resorbable membrane fixed with tacks. The implants are set in place in a digital planned position. And then the GBR 50% autogenous, 50% xeno is performed with a resorbable membrane fixed with 4 tacks on the buccal aspect and 2 on the lingual. This is the post-op X-ray where you can see the tacks and the GBR procedure, the vertical and horizontal augmentation, and the position of the implant. After 6 months of healing, we can go to the re-entry stage. And as you can see, the quantity and the amount of keratinized mucosa is not enough to allow the patient a good aesthetic and a good maintainability of the rehabilitation. So this 1.5 millimeter of keratinized mucosa is moved on the lingual aspect, and a free gingival graft is performed in order to gain the right amount of keratinized mucosa, which we know is at least 2 millimeters. Here you can see the surgical technique. First, a split thickness flap is raised, the muscles insertion are removed, and the periosteal bed is exposed. The muscles and the vestibule is then fixed in a more apical position following a vestibuloplasty technique. Then the implants using the surgical guides as a guide are reopened. The healing cap are removed. The healing abutment are set in place. This is the technique for the harvesting of the epithelial connective tissue graft with a crestal incision, mesial incision, apical incision, and then the distal incision. The collagen is fixed with cross matrices, as you saw in the previous video, and fill in with hyaluronic acid. After the free gingival graft is then moved to the recipient bed, to the periosteal bed, is then fixed with single 6-0 PGA resorbable suture. And it's very important to check that the graft is stable. If you see some movement, you add some single dot anchorage to the periosteal bed in order to have a stability of the graft in this recipient bed. Here is the post-op pictures, both of the recipient site and the donor site, where the collagen sponge is filled with the hyaluronic acid is in order to stabilize the clot and promote the first phase of the healing. This is 1 week and 2 weeks after surgery. And this is the palate at 1 week, where you can see some granulation tissue, and 2 weeks where you have a good healing. As we told you before, 2 months follow-up for the restitutio ad integrum. Digital scan was performed. Then these scans were superimposed, and the distance between each scan is measured in order to check how the test group react to hyaluronic acid application. This is another case. This is baseline vertical horizontal defect in the static area. Before in the posterior area, here we are talking about static area. A GBR procedure with non-resorbable custom titanium mesh is performed because the vertical defect was more than 3 millimeters. The titanium mesh is fixed with screw, and after 8 months is removed, and the implant is digitally planned and digitally positioned. After 4 months, 8 plus 4 is 1 year, we go to the re-entry stage. We use, again, the digital guide in order to have the exact position of the implant. We do a minimal T incision on the palatal aspect, as you can see here. And we move the tissue volume on the buccal aspect, as you can see on the right. This way, on the implant site, we have enough volume. We have to manage also the pontic area. The incision line is, yes, now is this one. And then this little palatal incision in order to expose the healing cap and remove the cap. Yes, the important thing is to stay palatal. If you use the surgical guide here, you start from this part, okay? And then you move all this volume on the buccal aspect in order to gain enough thickness, okay, to conditionate the tissue with the provisional restoration afterwards. The pontic area is then treated with a tunnel technique, with a crestal incision and a buccal incision also on the canine in order to improve the volume, because you know that these patients underwent also to a lot of surgery and a lot of releasing incision on the canine. So we want to increment also the volume of the canine. Then the soft tissue is grafted from the palate, is deepitalized in this case afterwards, and then is fixed both on the canine here, on the buccal aspect, and is important also on the crestal aspect, because here we're going to manage the pontic area with the provisionals in order to recreate a pseudopapilla. Here is the volume after the surgery. Here is the volume in the crestal aspect after the surgery, and this is the provisional delivery at the same stage of the reentry. This is the palatal donor sites at 7 days, where you can see still some granulation tissue, and at 14 days. This, we move directly to the definitive restoration, which includes a single crown on the lateral, a veneer, and then a bridge with a pontic, as I told you before. Here is the tissue after the provisional conditioning. Here is the pseudopapilla obtained with the connective tissue graft together, which is really important with the provisional conditioning of those tissue. And this is a detail of the papilla. This is the final restoration after 1 year follow-up. And this is the baseline together with the 24 months after op follow-up. So we discussed a posterior area rehabilitation and anterior area rehabilitation. We moved to a full arch rehabilitation. We know that these kind of implant rehabilitations are extremely common in our age. And we also know how hard it is for the patients to clean this kind of rehabilitation. And this for this reason, keratinized mucosa is really important in order to let the patients be able to maintain this prosthesis. Here, as you can see, the muscle insertions are directly on the implants, so a free gingival graft needs to be performed in order to obtain a good vestibule and a good amount of keratinized mucosa. For this reason, the patient is enrolled inside the protocol. The epithelial connective tissue graft is harvested in the palate and then is fixed on the buccal aspect, and the vestibule is repositioned, exposing the periosteal bed. This is the healing at 2 weeks, where you can see the new vestibule, and this is 3 months, 6 months, and 12 months follow-up. Not all the patients are so good to clean as these ones, but of course, the amount of keratinized mucosa and the good vestibule position let the patient be able to clean easily. Going directly to the results of our RCT, we can check the clinical healing evaluation. The Landry Healing Index, as previously mentioned, was used in order to analyze the clinical tissue healing, and we have significantly better healing score at 7 days and 4 days for the test group. Significantly less pain at 3 and 7 days in the test group, and less discomfort at 1 and 3 days, which are the days where the patient gets much more painkiller and usually have more pain and bleeding the first day after surgery. Absence of bleeding at 7 days in the test group with hyaluronic acid. Similar stress level, no statistical significant difference in the impairment. Less painkiller intake in the test group in the first 3 days. And for the restitutio ad integrum, again, significantly better results for the test group at 7 days. So, concluding, this is just one way to use hyaluronic acid in our clinical practice. We are actually testing with the University of Parma in a multicentric study the usage of hyaluronic acid in post-extractive third molar extractions in a split mouth RCT study. We are using it for root coverage, for periimplantitis treatment, for periodontal reason, and also for GBR in order to promote a stability of our graft. I will, together with Pierpaolo, thank you for your time, and we are here if you have any question about the protocol or.
Thank you. Thank you. Go ahead. Yeah, because our thought was that it can remain in situ.
Repeat the question.
Oh, so the question was why we put, because for technical reason, I have to repeat the question, and was why we put the hyaluronic acid in between the collagen sponge instead of layer outside. And the reason why is because in our opinion, it can remain in situ for a longer period of time, as we have seen from previous studies that when the hyaluronic acid was placed on the top of the collagen sponge, it disappeared pretty fastly. And some of the authors said that the reason why they didn't get statistically significant differences was related to the fact that hyaluronium was placed on the top instead inside the sponge. So taking into consideration these previous findings, we have modified a little bit the technique, and we injected the hyaluronic acid inside the collagen sponge. Yeah, this was the reason basically.
If I can add some information, the patients do not use chlorhexidine in the days.
They are not allowed to
absolutely.
use chlorhexidine. We
Because
use an ozone mouthwash. Ozone mouthwash because chlorhexidine is
Ozone.
supposed to be ozone.
Yes.
Yeah, it's
And-
supposed to be cytotoxic against fibroblasts in some studies.
And then after applying the hyaluronic acid, you place a gauge and you leave it for 2 hours, and you do not let the patient wash his mouth and rinse and eat or drink for 2 hours. Okay, or eat or drink for 2 hours. He stay there with the gauge for 2 hours at home or wherever, and then he can remove it, because this way the clot is stable and the hyaluronic acid is. Yes, with the gauge.
Yeah.
Yes.
Because Prof. Sculian yesterday clearly showed that already in the first minutes, the blue clots interact with the hyaluronium and stabilize. So it is crucial and pivotal in this phase to have a really stable blood clot. And this is the reason why the patient is not allowed to do nothing for the first 2 hours. Yes. Yes. Yeah, it goes. Yes, it goes. A big goes. He closed the mouth and stay like that. Yeah.
Yeah.
Yes. So the colleague asked why we used directly the collagen sponge without any protection. And yeah, actually, we do not have experience. I mean, not experience, but in this case, we didn't use a periodontal dressing. Some study used it, other studies didn't use it, and other studies used a stent for the first 7 to 10 days. And amongst all of them, I was not able to find any differences in terms of protection of the hyaluronium and the sponge in that case, but probably it would be better to put something to protect the collagen sponge from the saliva to contaminate the site, probably. But I'm not sure from the literature how this might interfere with the healing in their immediate phases, because the literature is pretty conflicting in this aspect. Yes. With cyanoacrylate glue. Yeah, and I would say that cyanoacrylate glue was one of the methods that was mostly documented and provided the best level of pain reduction and epithelialization. So I would say that technically would be possible, but I don't know from a molecular standpoint if we will interact with the hyaluronic molecules. I don't know that. We should. This is too much technical answer for me. But so the colleague was asking if cyanoacrylate glue could be used in conjunction with the hyaluronic, but I honestly don't know molecularly if the cyanoacrylate glue can interact with hyaluronic. Yeah.
Okay. Thank you very much.
Thank you so much. Thank you so much for your time. Thank you. Thank you. I don't know if the cyanoacrylate glue interacts.
No, it doesn't.
I don't think so, but I'm not sure from
Da quello che so io ci sono anche studi che li hanno uniti.